Welcome to Learn About Eyes video rounds. I'm Lorenz Kuske, a glaucoma, cataract, and complex anterior segment surgeon based in Switzerland but trained in Canada by Ike Ahmed. In this series, I take real surgical footage, slowed down, annotated, and explained to show you the fine details of surgical technique, decision making, and complication management. So let's dive right in.
Okay, here we have a case of a Phako bang in a patient with an asteroid hyalosis and a couple fun things to talk about. So normal paracentesis. We're doing on our incision. Capsulorhexis. In these cases with asteroid hyalosis, your contrast and your red reflex is usually pretty bad, or can be horrible if it's very bad hyalosis. In this case, it was pretty simple, but still, you can see it's not that easy to see the capsulorhexis, and as we will see in the end, it won't be perfectly round. Now we're doing our hydrodissection, and we're already noticing that we have quite some ballooning going on here. We're going to need to fix that early on, otherwise we're going to run into problems later. Now here's a tip. What I usually do, I take a chopper and I just use it to open up the conch. This can be done very simple, little cut in the conch, and then you can just massage out the BSS from under the tenons. Remember, tenons is like a sponge, so it's not like one fluid filled cavity. It's a sponge that you need to squeeze out. Now we're going in with the Phako tip. In this case, actually the chop technique was not perfect. I'm gonna go through this very fast. I'll use this video on how to do chop or not do chop in a later video. And there you can see me do another quick release for this ballooning happening here. Now lens is out, cortex is being removed. Everything's so far going great. Now we're filling the capsule with viscoelastic and we want to inject the lens. What can we see here? Lens is going in, and since I'm doing a bang afterwards, I'm not using the IA to put the lens in the bag. So I'm just using a spatula. I'm thinking I'm in the bag. I'm rotating gently, but it doesn't really seem to move as easily as I'm used to. And now I'm looking at this area and I'm kind of a bit worried about how it looks. So I stop. Very important thing. If you're not sure, always remove the bubbles. So I'm using a half-filled BSS syringe and I'll just aspirate out that bubble. Very important, always improve your visibility. I'm zooming in to watch what's going on here, and we can see capsulorhexis right here. It's perfectly over the optic. Here it's doing something weird. It's going here in like a triangle shape. So this means that the haptic of the lens is actually in the sulcus back here. What do we do now? This is a hook going in, capturing my lens haptic, and now we can actually see the fact that I can actually grab it without moving the rhexis or without destroying the anterior capsule means it was indeed in the sulcus, and I'm just using the hook to push this elbow of the lens into the capsular bag. Now the elbow is in. Now I'm using the hook to put the rest of the haptic into the bag, and we're done with that. and we have our lens perfectly placed here. Now we're going to the bang part. I usually refill the angle a bit with some dispersive viscoelastic. This is a 2% hyaluronic acid. I'm using a 27 gauge needle and I bend it. You can see it's a bit tilted here. Now I straighten it out. 27 gauge needle, bent 90 degrees. Now I've tilted the patient's head. I'm using a gonio lens. And you can see the TM very clearly here, nicely pigmented TM. And I'm just slicing it open. This is kind of like a cheap Kahoot dual blade. And there's a good learning when you do this. So here's the Phako wound. You don't want to be pulling the instrument this way. You want to be in the wound and rotating it this way so that the other side rotates back. And that's what I'm doing here. I'm rotating. Let's go back. So here I'm noticing that I'm actually pulling this way. So what I do is I take this and I rotate it over to get a better access to this part of the TM. You can really see the back of Schlem's canal nicely. This white shine. Good, and we're done with that. We just tilt the patient's head back. Just got to clean up the viscoelastic. And actually here you can see some TM hanging into the AC. You can remove it or leave it. Doesn't cause any inflammation from my experience. And then we're just removing the viscoelastic and we're done.
That was it for this video. Thank you for watching. Do you still have any comments about that surgery? Please use the comment section down below to ask your questions or add additional information. And don't forget to like and subscribe for more content like this. Have you heard about my online courses? If not, please check them out in the link in the description down below. See you in the next one.